Good evening, sir.
Dr. Durai Arasan, sir. Good evening. Vanakkam, sir.
Vanakkam, madam. Vanakkam. Good evening, madam.
Good evening, madam.
Vanakkam,
Good evening, sir.
vanakkam.
Good evening.
Good evening, sir. Srinivasan, sir.
Good evening.
Raghunath,
Everybody says, sir.
Yes, sir. Good
I
evening,
tell my
Durai,
PG
sir.
students also not to call, sir.
At
This
least you
child,
should
sir,
accept
presented,
it because
sir.
of age-wise, sir.
Yes, sir.
Now, there was one PG
You may
who
be
always
young
said,
at heart.
everything, this child, sir, presented, sir, with cough, sir. I said, for every, sir, I am going to cut a half-day salary and put it in the poor patient box. Okay, poor patient box was there in this thing. And finally, he became the gold medalist, beating some of the best students from various parts of this thing. No, among the 6 PGs, he was this thing. But when he was from a rural background, and now, of course, now he is a professor in JIPMER, pediatrics. Yeah.
Sir, share ಮಾಡಿದ್ರಾ sir? Check ಮಾಡಿದ್ರಾ?
You know, Tamil Selvan, who was in Bangalore, he is also in staff
Yes, sir.
in this thing.
Yes, sir.
He is also staff in, professor in
JIPMER, sir. Yes, sir.
Yeah.
He's our examiner, sir. Whenever we need, we call, sir.
Yeah.
Srinivasan sir was my examiner.
Sir was our type.
That examiner.
Sharad, good evening.
Good evening, sir. Sharad, sir.
Good evening, Sharad.
Sharad is muted.
Sorry, sir. Hi, everyone. Hi, sir. Durai, sir. Good evening, sir.
Good evening, sir.
Good evening. Srinivasan sir is always there, sir. I think you are in US. You are telling no, sir. Time zone is different.
Yeah. Till October.
And still, you are promptly there, sir, at 9 o'clock. Very nice of you, sir.
Yeah, thank you. Learning is a continuous process.
Yeah, yes, sir.
If we don't
And
send,
that too with,
we'll ask, is there no link to the
people.
Dr. Jose, sir, good evening.
Good evening.
Good evening.
Good evening,
Jose, sir. Good evening.
Good evening, Jose, sir.
Good evening.
Good evening.
Jose knows that I am one of the IAP Kerala's regular student.
Yeah. Every Thursday at 7:30.
Jose, sir, good evening.
Good evening, Nandesh.
Sharath, good evening.
Nandesh, good evening.
Sharad, good evening.
Sir, Basara, sir, join ಆಗ್ತೀನಂದಿರಾ?
Sharad, sir, as a program, I don't think he will be able to.
1, 2, 3 minutes, we'll wait.
Yes.
Then,
Yes, sir.
And seeing you, all of you, gives me energy. Yeah, like a dynamo. Because you're all contributing so much for academics.
Yeah, definitely.
Dr. Nandesh.
yeah, we will start, sir. Sunilji,
Sir,
please.
we'll start, sir.
Yeah.
1 second, sir. I'll start. Recording will start. Good evening, respected members. On behalf of IAP Bangalore, I would like to welcome you all to this wonderful Great Bangalore Connect program. First and foremost, I would like to welcome Dr. Raghunath sir, our President IAP Bangalore, our President-elect Dr. Sharat Chand sir, Dr. Sumita Nayak madam, past President and VP Bangalore Zone, and Dr. Jose Susef sir, South Zone VP. Our speaker for today, Dr. Durai Arasan sir, Dr. Nandi sir, coordinator, convener for this program, and all the EBs, OBs, and all the delegates who have joined for today's webinar. I would like to request Dr. Raghunath sir to give his opening remarks, sir.
Good evening, everybody. Thank you, Sunil. It's a wonderful day here. We have about 40 people already enrolled, and we are looking forward for many more people. It's been a successful program which has been conducted by Dr. Nandi, who has been the coordinator for this program, convener and coordinator, who is selecting a very good topics for and which is helping our postgraduates as well as the practicing pediatricians to update their knowledge and to be on par with the recent guidelines. So we welcome Dr. Joseph Sapan, who is the Vice President of the Bangalore South Zone, who has graced this occasion. And we also welcome Dr. Srinivasan sir, who is continuously attending all our programs and making our program very successful. He has few comments and he will always update us with more knowledge. And we welcome Dr. Durai Arasan sir. Durai Arasan sir is a very eminent pediatrician. He is a professor of pediatrics, nodal officer of COE RD, and nodal officer for District Early Intervention Center. He is in the Department of Pediatrics Institute of Child Health at Child Health and Children Hospital, Madras MMC, Chennai. He has done his MBBS from Dr. MGR Medical University and MD Pediatrics from MG Medical University, MGR Medical University. NRP National Inspector 2009, membership roles in Pediatric Professional Organization. He is IAP member, NNF member of IAP Dermatology Group, editor-in-chief of IJPP. This is one of the very acclaimed position, and we look forward for Dr. Durai Murugan, Durai Arasan, to update the knowledge on UTI. UTI it's a more common infection which is usually missed by many of our pediatricians as well as the practitioners. So with this background, I would welcome Dr. Durai Arasan, and we request Jose Usapan to speak few words before we start. Over to you, Dr. Jose.
Thank you, Raghunath sir. Thank you, the Secretary of IAP Karnataka chapter, Dr. Sulkumar, and the convener of the today program, Dr. Nandesh, Dr. Sundar Naik, and Dr. Basaraji, the President of past President of Central IAP, our good friend and always the delegates in our all the South Zone teaching program, Dr. Srinivasan sir, our doyens in the academics. And today the dealing faculty, Dr. Durai Arasan, is the editor of pediatric IJPB, and again he is my co-EB from South India, and my dear delegates and dear friends. First of all, congratulations to IAP Bangalore team, taken the leadership to organize regularly most important day-to-day practice issues for updating the knowledge regarding the day-to-day general practitioners issues. Today we are going to have another important topic because that urinary tract infection is one of the common general practitioners concerns. So there are different pattern of presentation, and regarding the updates regarding the change in the pattern happen regarding the view of increase there to regarding the urinary tract infection prophylaxis and pediatric practice concern. I think the urinary tract infection is one of the common in day-to-day practice, especially any patient in infancy present with prolonged fever. One of the common scenario general practitioners consider urinary tract infection without any localized symptoms. So to say that to diagnose urinary tract infection, there are different urinary tract infections, the urine culture and sensitivity, but the collection samples is very, very important to make a good culture report for urinary tract infection. That is a very tricky package in the or pediatric investigation modality concern. I think today Dr. Durai sir is going to enlighten all of us regarding how to tackle, how to confirm the urinary tract infection in a simple way. And again, I congratulate Dr. Nandesh and team for excellent activity for national level you are conducting. And all the best program. Jai Hind, JAP. Over to Dr. Jagannath and team for further proceedings. Thank you, sir.
Thank you, sir. Thank you, sir. I would like to request Dr. Nandi, sir, to start the session, sir.
Thank you, Dr. Sunil.
Thank you, sir.
Very good evening to all the esteemed dignitaries present today. We are very thankful to have Dr. Durai Arasan as speaker for the today's session, Bangalore Connect, the most successful academic program initiated by Dr. Sumita Naik, the Vice President of IAP Karnataka, and well taken ahead by Dr. Raghunath, popular President of IAP Bangalore, under the assistance of Dr. Sunil Kumar and guidance from us all executive board members. We thank our Vice President South Zone, Dr. Joseph, for always being with us and being the guiding force in all our academic activities, and for all the doubts or help we need, he is always with us. We are very thankful for all the delegates, PG students, and our past Secretary General Dr. Yogesh Parekh, Dr. Geeta Patil Madam, and senior Dr. Sadagopal Srinivasan sir, who is always with us for continuous encouragement in our academics. Thank you all. Over to you, Sunil Kumar. Let us start the academics for Durai Arasan and try to understand the best of the best knowledge about the urinary tract infection. Over to you, Sunil sir.
Thank you, sir. I welcome Dr. Yogesh Parekh, sir, also to this program, sir. Welcome, sir. Sir, over to you, sir. Dr. Durai Arasan, sir.
Good evening, sir. Good evening to one and all the dignitaries, especially to the President, sir, Dr. Raghunath, sir, Dr. Sunil, sir, the Honorary Secretary and Treasurer, Dr. Raghu, sir, and our friend, Dr. Nandesh, sir, for inviting me to this, and all the seniors from Dr. Srinivasan, sir, Sumita, madam, Geeta Patel, madam, Yogesh, sir, and Jose, sir. So, a very warm good evening. Taking a topic which is very common and day-to-day dealt by every pediatrician, it also gives me a jitteriness that I should do justice to it. So hope I will be able to do justice to the topic. So shall I share my screen, sir?
Sure, sir. Sure, sir.
Is it visible, sir?
Yes, sir. Yes, sir. It's visible, sir. You can start, sir.
Yes, sir. So urinary tract infection in children is a common problem which every pediatrician encounters day in and day out. So why on discussion with Nandesh sir we chose this topic is because of its commonality. If you take any febrile infant or young child, around 5% of the children have urinary tract infection, which is an observational study by the Urological Society of India. And Around 2% of the boys and 7% of the girls experience at least one episode of urinary tract infection before the age of 6 years. So it is so common, and around 20 to 30% of these children have underlying congenital abnormalities. So only if we suspect and identify urinary tract infection, we can identify the underlying congenital abnormalities and manage them accordingly. And moreover, 10 to 15% of these febrile urinary tract infections or acute pyelonephritis may develop kidney scarring, which can give rise to long-term complications like hypertension, growth faltering, chronic renal problems. So it is important to update ourselves about the urinary tract infection and its guidelines. So we all know, though being very common urinary tract infection, it lacks specific symptomatology, and the symptoms are varied depending upon the age and the development of the child. So it is more difficult in a pre-verbal child or a children less than 2 years, where the symptoms are going to be very much non-specific, like fever, poor feeding, vomiting, lethargy, dehydrated and decreased urine output, irritability. Whereas in older children, verbal children who can communicate, the lower urinary tract symptoms can be very much present, like dysuria, suprapubic or non-localized abdominal pain, increased urinary frequency, new onset enuresis in a child who is already not having any problem, increased urgency or hematuria. Whenever there is a fever, vomiting or flank pain is present, we suspect an upper urinary tract infection. So given the varied symptoms and non-specific symptoms, we have to be on high alert to suspect an urinary tract infection, especially when there is a fever without a source, a temperature of 38 degrees in children less than 3 months of age, and a temperature of 39 degrees centigrade in children more than 3 months of age, lasting for more than 24 hours, especially in uncircumcised boys and girls of age less than 2 years. The risk factors to be considered along with your clinical risk symptoms are especially vesico-ureteric reflex or other urogenital malformation, bladder bowel dysfunction, which is specifically peaking in the school age children, or previous history of urinary tract infections or recent bladder catheterization. All these should give us a suspicion that this fever is possibly because of an urinary tract infection. Once you suspect an urinary tract infection, the clinical examination is important. Mainly examination of the external genitalia. You look for phimosis, hypospadiasis, labial adhesion in female children, or any other urogenital abnormality. The costovertebral angle tenderness, if present, signifies pyelonephritis, and a palpable bladder could be because of an obstructive uropathy. A palpable kidney could be because of an hydronephrosis, or a palpable fecal mass could be secondary to constipation. Don't forget to examine the lower back for signs of occult meningomyelocele and the lower limb for neurological examination to identify a neurogenic bladder. Once we have decided to suspect an urinary tract infection, the most important thing is confirming it, and for which the urine analysis and the urine culture is the gold standard. And collecting the urine is a nightmare both for the clinician as well as for the parents, and especially in a non-toilet trained stable children, it is very, very difficult. So there are two options if the child is going to be stable. So always attend clean catch methodology. Only if it is unsuccessful, then go in for catheterization or suprapubic aspiration. The American Academy of Pediatrics recommends usage of non-invasive means, that is urinary bag sample, for preliminary urine analysis to check for pyuria, nitriuria or bacteriuria. If it is going to be positive, then you can go in for a catheterized or a suprapubic aspiration sample for repeat urine analysis and urine culture. Whenever the child is going to be sick, septicemic, or you suspect an urosepsis, then catheterization or suprapubic aspiration is the preferred method for urinary collection. In non-toilet trained stable children, there are some special techniques by which you can collect the urine by clean catch. There are two methodologies. One is a quick wee method. The other one is a bladder stimulation method. In the quick wee method, you allow the infant to feed for up to 20 minutes. Clean the genitalia with an antiseptic solution like povidone iodine. Then apply cold liquid. A refrigerated saline soaked gauze is used for this purpose over the suprapubic region, either until the urination occurs or up to a maximum of 5 minutes. We will see it as a video. Here the sterile dressing, the sterile forceps and saline and water, refrigerated, which is cooled. So after feeding the baby, you can just apply the cold saline soaked gauze over the suprapubic area and then stimulate so that you can get a good clean catch urinary sample. The second methodology is bladder stimulation technique. Similarly, you feed the baby for 20 minutes, clean the genitalia, ask one of your assistant to hold the child under its arms with the legs hanging down in the males, or you can even flex the hip as in the females. And another person holding the sterile urine cup to collect the urine. Now gently tap the bladder. The frequency here is going to be more important. You have to gently tap at a frequency of around 100 times per minute for 30 seconds, alternating with an paravertebral massage. So this is the way you hold the baby under its armpit, then perform a bladder stimulation. The frequency, it has to be very gentle and very fast, 100 taps per minute, alternated with an lumbar paravertebral massage, 30 seconds of bladder stimulation, 30 seconds of paravertebral massage until you get the urination, or till 5 minutes. So most of the time you will be able to collect and clean catch. If you are not able to do it, then go for an catheterization or an suprapubic aspiration. If the child is going to be toilet trained, yes, clean catch is the method of choice. And remember, the labia should be spread. The perineum should be cleansed at least 2 to 3 times with antiseptic solution or mild soap. And in the males, similarly, the meatus should be cleaned, and you should retract the foreskin in uncircumcised males. Then the contamination will be less. So summarizing the urinary collection method, the clean catch method, the success rate is variable and the contamination rate is around 5%. If you take the first stream, it is around 5 to 7%. If you take the late stream, it is around 0 to 2%. So generally what is our teaching is midstream urine to be collected, which is less than 5%, and this is the best method which can be done. Suprapubic aspiration, normally done under ultrasound guidance, the success rate is around 90% and the contamination rate is the least if you are taking all the universal precaution. Catheterization has the highest success rate in collecting the urine, but the contamination rate is 8% because the periurethral and the lower urethra contains the common cells and they are possible contamination. It is around 8%. The samples from adhesive bags and nappy pads have high degree of contamination and these are not to be used for culture, but as per AAP recommendation, you can use it for urine analysis as a preliminary methodology. Once the urine collection is done, it has to be examined as early as possible, freshly voided. So within 1 to 2 hours, if it is left in the room temperature, or if you feel it is going to be delayed, refrigerate it and you can do it within 4 hours. The microscopy, which is the age-old technique to look in for the leukocytes, more than 10 leukocytes in an uncentrifuged sample or 5 leukocytes in a centrifuged sample, it has got a specificity and sensitivity which is more varied, because leukocyturia alone is not sufficient, and you can have leukocytes or leukocyturia or pyuria in febrile illnesses, in Kawasaki disease, in glomerulonephritis, any kidney stones, foreign bodies. So leukocyturia presence is going to be, though it is going to be sensitive, it is not that specific for an urinary tract infection. Also remember, around 10 to 15% of the children may have urinary tract infection in the absence of leukocyturia, especially in organisms like Enterococcus, Klebsiella, and Pseudomonas aeruginosa. The bacteriuria if present, has an excellent specificity, but you need to have an oil immersion microscope to look in for bacteriuria, and it has also gotten good sensitivity. Combining both positive leukocyturia and bacteriuria, it doesn't alters your specificity and sensitivity, so either one is going to be good. But we have moved from the age-old technique of microscopy to the urinary dipstick method. The leukocyte esterase, which is an surrogacy for your pyuria or your leukocyturia. Again, the specificity and sensitivity is varied because you can have leukocyturia in varied condition. Whereas your urinary nitrate test has an excellent specificity. If it is present, it is confirmatory like 99%, but it has gotten very poor sensitivity. We will see why in the next slide. The presence of either and positive leukocyte esterase or nitrate has a good specificity and good sensitivity, and this is the recommended standard of care examination for urine methodology. So if you look at the urinary dipstick for nitrate positivity, there are only certain bacteria which can reduce the urinary nitrate to nitrate, and the common E. coli does it, Pseudomonas klebsiella and some staphylococcal species does it, whereas your streptococci and enterococci do not reduce the urinary nitrate. It is not enough if the bacteria is present in the urine. There should also be an incubating time of around 4 hours for these bacteria to act on your nitrate to nitrate. That is why the sensitivity is very less, especially in infants who used to void every 2 hours or 3 hours once. The time for incubating the nitrate to nitrate is not there, so it is difficult to pick it up. Also, there should be an dietary nitrate in your diet, and it comes mainly from your green leafy vegetables and root vegetables. So summarizing the urinary dipstick test, whenever there is a specific urinary symptoms or fever without focus for more than 48 hours, especially in children less than 2 years, or there is a presence of risk factors. What are all the risk factors? A bladder bowel dysfunction, primary vesico-ureteric reflux, or a previous history of urinary tract infection. Then do an leukocyte esterase test or nitrate test through your dipstick. If either of it is going to be positive, start on empirical antibiotic and wait for the culture report. Suppose if your leukocyte esterase and your nitrate both are going to be negative, then look in for risk factors and age of the baby. If the age is going to be less than 6 months and there are going to be risk factors of bowel bladder dysfunction or primary vesico-ureteric reflux or UTI, even if your leukocyte esterase and nitrate is going to be negative, you start on an empirical antibiotic and then wait for your urinary culture to confirm. If no risk factor, child more than 6 months and both are negative, you don't have to start on an antibiotic. Wait for your cultures to come, and after your culture report, you can start on an antibiotic. So now moving on to urinary culture, the sample should be processed as promptly as possible. As we said, if you are going to get it delayed, please refrigerate at 4 degrees centigrade to prevent bacterial overgrowth. And it is important to differentiate between true infection and contamination, because the periurethral area and the distal urethra are colonized by the same organisms which may cause the urinary tract infection. So there are cutoffs which guide us to confirm the urinary tract infection in your urine culture. But always remember, the cutoffs are only guiding principles, and their pre-test probability, how strongly you suspect your urinary tract infection, has an weightage. That too, especially in infants who voids more frequently, and whenever we are suspecting a non-E. coli uropathogen, the colony counts may not be that good. So this is an online calculator to check for the pre-test probability of urinary tract infection. Again, your age, the maximum temperature, history of urinary tract infection, uncircumcised male or a female child of less than 2 years, fever without focus, and duration more than 48 hours. All these will give you what is the probability that it could be an urinary tract infection. So the guidelines says the cutoffs for clean catch has been now reduced from 10 to the power 5 colony forming unit to 10 to the power 4 to 5 colony forming unit. So it especially in infants. In suprapubic aspiration, any bacterial growth is significant. In a catheterized sample, a cutoff of 10 to the power 4 confirms your urinary tract infection. This cutoff of 10 to the power 5, which was an historical cutoff, has been changed because many studies where simultaneously suprapubic aspiration and clean catch methodology were done. The children had confirmed 10 to the power 3 colony forming unit in suprapubic aspiration, but failed to confirm with a clean catch sample of 10 to the power 5. So if we still follow the cutoff of 10 to the power 5 colony forming units, around 10 to 25% of children with urinary tract infection may be missed. So the cutoffs has been lowered to 10 to the power 4 to 5 colony forming units by your clean catch method, especially in infants and high risk children. The treatment part of it should be initiated as early as possible within 48 to 72 hours. Delaying can lead to the risk of kidney scarring, so there should not be any delay. Oral antibiotics are equally effective as parenteral antibiotics. And third generation cephalosporin, cephalexin or coamoxiclav as your initial empirical antibiotic therapy is very good. Anyhow, your local sensitivity pattern has to be given significance while selecting the antibiotic. Intravenous antibiotics are indicated in the following situation, especially in infants less than 2 months of age, in septicemic or you are suspecting an urosepsis severely ill child or child who are not able to ingest orally. Even if you are going to start on an IV antibiotic or parenteral antibiotic, it can be switched over within 3 to 4 days once the child is going to be stable and starting to take orally well. Almost 90% of the children resolve within 48 to 72 hours. If you are not going to have a good clinical response within the time of 48 to 72 hours, suspect a non-sensitivity of your uropathogen and repeat your urine culture specimen and do an ultrasound to look in for complications like your pyonephrosis, renal or perirenal abscesses, or features suggestive of obstruction or any other congenital anomaly of the urinary tract. You need to drain the urine when there is an obstruction, the infected urine, for the infection to get controlled. The course of the antibiotic therapy in an acute symptomatic or acute pyelonephritis is 7 to 10 days. In children with lower urinary tract infection where it is only cystitis, 3 to 7 days of therapy is recommended. So whenever you confirm an urinary tract infection, if it is cystitis, especially in older children and adolescents, it is 3 to 7 days. If it is in febrile UTI or in pyelonephritis, the course is 7 to 10 days. And if the child is going to be less than 2 months, septicemic with poor oral intake, then 3 to 4 days of antibiotic and then switch over to oral antibiotics. A word about asymptomatic bacteriuria. It is not advisable to do urine culture when the child is not symptomatic. So don't do urine culture in an asymptomatic children. And majority of the asymptomatic bacteriuria resolve spontaneously. And many studies have shown from a period of around 1.5 months to 2.5 years. So you can give antibiotic whenever you are doing an instrumentation, that is catheterization or any investigations. Apart from that, an antibiotic is not needed for asymptomatic bacteriuria. Is there any role for adjuvants apart from your antibiotics? Yes, corticosteroids and vitamin A therapies has been studied, but nothing have shown beyond doubt, and they are not recommended as a routine in preventing the kidney scarring. Yes, cranberry juice has been shown to prevent recurrence of urinary tract infection because they contain proanthocyanidins, which prevent your E. coli from adhering to the bladder wall. But to get this amount of proanthocyanidins, you need to drink 300 ml of cranberry juice daily, and making the child to drink it daily is going to be difficult. Once you finish treating your urinary tract infection, then we need to follow it up with an imaging study, and all children diagnosed with urinary tract infection should undergo an ultrasound scan. And in this ultrasound, you look at the size of the kidney, abnormal echogenicity, pelvic axial dilatation, ureteral dilatation, uroepithelial thickening of the renal pelvis, bladder wall thickness, and bladder diverticulum. you can do an MCU, micturating cystourethrogram, after completion of the antibiotic therapy, and it should not be done before that. The current guidelines or the recent recommendation is less aggressive approach of imaging. Previously, we used to do DMSA MCU for every child less than 1 year, and for children around 1 to 5 years, we used to do an ultrasound and a DMSA scan and MCU if DMSA is abnormal. Now, they have moved away from it, and an MCU for diagnosing VUR is advised only if there is going to be an abnormality, because there is a discomfort of urinary catheterization and exposure to ionizing radiation by doing a micturating cystourethrogram. And studies have shown that vesicoureteric reflex is present only in 30% of the children diagnosed with urinary tract infection. So if you make it as a guideline in all, other 70% of the children will be undergoing unnecessary investigations. And studies have also shown that no intervention in the sense antibiotic prophylaxis, surgical implantation, endoscopic correction has been proved to be beneficial in reducing the kidney damage secondary to VUR. So it is not mandatory to do the investigation in all the children. You can select the babies. So imaging following your urinary tract infection, after all the first episode, do an ultrasound. If your ultrasound is going to be abnormal, then go in for a micturating cystourethrogram. If your micturating cystourethrogram shows VUR or of grade 3 to 5, or there is a recurrent urinary tract infection, then go for a DMSA scan. If your ultrasound is normal, you just follow it up, that is enough. In children where there is a recurrent urinary tract infection or a non-E. coli urinary tract infection in children less than 2 years, you can do an micturating cystourethrogram even if your ultrasound is going to be normal. So ultrasound is indicated in all children with urinary tract infection. You go for micturating cystourethrogram if it is abnormal, or there is history of recurrent urinary tract infection or a non-E. coli uropathogen in children less than 2 years. The DMSA scan, you can do it at 2 times, one in the acute phase and then in the late phase. In the acute phase, it is to detect your pyelonephritis. That is normally done within 2 weeks, but generally ultrasound is going to be good enough. We don't go in for a DMSA scan. A late phase DMSA scan at 4 to 6 months is going to be useful to detect a permanent kidney scarring, so that you can follow it up and then treat it accordingly. Prevention of your recurrent urinary tract infection is the most important thing after properly diagnosing and treating an urinary tract infection, because around 10 to 30% of the children may experience a recurrence of urinary tract infection, and out of that, around 17 to 18% of the children get a recurrence even with a normal urinary tract infection. There is no normal urinary tract anatomy. So even without any abnormality of the developmental urinary tract, around 17 to 18% of the children can have a recurrence within 24 hours. So it is important to prevent the recurrence. And 10 to 15% of these children can go in for complications of kidney scarring and long-term problems. So what are the most important risk factors for recurrence of urinary tract infection? The most important recurrence is primary vesicoureteric reflex and bladder bowel dysfunction. So we will see how to manage both. What do we mean by bladder bowel dysfunction? There is a co-occurrence of both urinary symptoms and bowel issues, especially like constipation or soiling. Remember, all toilet trained children diagnosed with urinary tract infection should be evaluated for bladder bowel dysfunction, because the prevalence of bladder bowel dysfunction in patients with urinary tract infection is around 41%, which is very high. So all children who are toilet trained diagnosed with urinary tract infection, don't forget to evaluate for bladder bowel dysfunction. How to identify bladder bowel dysfunction? History of incontinence, frequency, urgency, and avoiding postponement symptoms like crossing one's legs or pinching the glands of the penis between the fingers or squatting with the heel at the perineum, and history of constipation by asking for the stool firmness, frequency, pain while defecating, and or encoparesis, and examination of a fecal mass in the left iliac fossa. The clinical evaluation should be supplemented with an voiding diary for 48 hours. Any voiding less than 4 times in 24 hours or more than 7 times in 24 hours is abnormal and needs further evaluation. And the bowel movement should be checked for over 2 weeks. It is more important to check it over 2 weeks. It is very difficult in non-toilet trained children to diagnose an bladder dysfunction. So what is recommended is an 4-hour observation of voiding. So you need to check the baby for the volume of void and the post-void residue every 5 to 10 minutes for 4 hours, and check whether the child is having an increased frequency, whether the volume of void is good, and use an ultrasound to check for an post-void residue. It is very difficult, but you have to be alerted to identify an bladder bowel dysfunction in a non-toilet trained children. Ultrasound plays a major role in diagnosing your bladder bowel dysfunction. The transrectal diameter can be used as a simple, reliable tool to document fecal loading in children. Similarly, the post-void residual urine of more than 20 ml or 10% of the bladder capacity in children aged 4 to 6 years, or a post-void residual volume of more than 10 ml or 6% of the bladder capacity in the age group of 7 to 12 years confirms there is a possible compression and post-void retention of urine. The bladder wall thickness also gives us a clue whether there is a bladder bowel dysfunction. More than 5 millimeters if the bladder is empty, or more than 3 millimeters if the bladder is full because of effacement. These two are suggestive of a bladder bowel dysfunction on an ultrasound. So ultrasound is a very good guide to suspect and diagnose a bladder bowel dysfunction. Once you diagnose a bladder bowel dysfunction, urotherapy is the management of size. Urotherapy is nothing but you need to maintain a voiding diary in every child, increase the fluid intake in the children, and there has to be a scheduled and timed voiding. Every 2 to 3 hours, make the child compulsorily go to the toilet and try to void, and advise double voiding. After the child finishes the voiding, ask the child to sit and urinate again right after they void. So double voiding is advised, and also avoidance of all C's, carbonated drinks, caffeine, chocolate, citrus fruits, and food colors are supposed to be very important in causing bladder irritation. So for your bowel clearance, adequate posture while sitting for toilet with both the feet supported on the stool or on the flat surface. So the southern toilet is going to be the best. If you are going to use the western toilet, try to rest both the feet. And bowel regimen. Bowel regimen consists of good hydration, increasing the intake of the fiber, and toilet training. The child has to sit at least for 10 to 15 minutes and not rush out as soon as they pass an stool. So the bowel training is going to be more important. If you are not able to achieve it, then go in for your stool softeners like PEG, which can be given for first 3 days for disinfection and then followed by for maintenance. The pooled cohort studies of around 7 cohort studies have shown a success rate of 70% following this urotherapy alone. So if you are not able to achieve a good remedy by your urotherapy, then you can go in for drugs like anticholinergics, especially oxybutynin, which can relax your detrusor muscle and decrease the urinary urgency, frequency, and leakage, and help in the recovery from your bowel bladder dysfunction. The next important risk factor for recurrence of urinary tract infection is your vesico-ureteric reflex. We all know it has got around 5 grades. The primary focus in the management of primary vesico-uretary reflex is only prevention of recurrence of urinary tract infection, because even highest grade of your VUR resolves spontaneously over time. So you don't have to hurry in to do any surgeries. So just maintain a good antibiotic policy and prevent recurrence of your urinary tract infection and observe it. Because the vesico-ureteric reflex increases the risk of kidney scarring because of the reflex in the urine. But remember, it is not only because of the infection ascending to the kidney. Around 7 to 17% of the children with vesico-ureteric reflex have congenital hypodysplasia of the kidney. So it is not always that the infection is at fault. They are de novo having congenital hypodysplasia. which is the cause for your kidney failure in vesico-ureteric reflux. So antibiotic prophylaxis should be the first line of management, and surgical implantation should be considered only when your appropriate management for bladder bowel dysfunction fails and you have breakthrough febrile urinary tract infection when the child is on antibiotic prophylaxis. Once you decide on a surgical intervention, open ureteric reimplantation is preferred to endoscopic correction because the success rate, they say, is good with open ureteric reimplantation. So primary vesico-ureteric reflux, if it is low grade, no urinary tract infection, nothing to be done. Low grade with urinary tract infection and bladder bowel dysfunction, you may need antibiotic prophylaxis. Higher grade, grade 3 to 5, antibiotic prophylaxis irrespective whether the child has bladder bowel dysfunction, or if there is a recurrent urinary tract infection on antibiotic prophylaxis, you need to go in for a surgical repair. So what are all the conditions where we use to re-emphasize antibiotic prophylaxis in higher grade, grade 3 to 5 primary vesico-ureteric reflux? Whenever there is a recurrent febrile urinary tract infection with lower grade vesico-ureteric reflux, you may consider prophylaxis if there is recurrence. And recurrent urinary tract infection with bladder bowel dysfunction, even in the absence of vesico-ureteric reflux, you may consider prophylaxis. And always put the child on prophylaxis if you have a frequent recurrent urinary tract infection, which by definition is 3 episodes of febrile urinary tract infection in 6 months or 4 episodes of urinary tract infections in 1 year. So the antibiotic prophylaxis, we know it is two, mainly your cotrimoxazole and nitrofurantoin. In children more than 3 months of age, in children younger than 3 months, cephalexin is the preferred drug. And nitrofurantoin is more effective than cotrimoxazole, and the bacterial resistance is higher for cotrimoxazole than nitrofurantoin. But the problem is the gastrointestinal side effects and urine discoloration. Sometimes the compliance may be poor. When to stop this antibiotic prophylaxis? Always remember, the antibiotic prophylaxis should not be stopped before the age of 2 years. The child has to be older than 2 years of age. The child has to be toilet trained, and there has to be absence of bladder bowel dysfunction and no febrile urinary tract infection in the preceding 1 year. Then you can stop the antibiotic prophylaxis. So because antibiotic prophylaxis is not without any risk factor, and studies have shown 3-fold increased risk of resistant organism causing urinary tract infection in children who are on antibiotic prophylaxis. So there is an other school of thought. Without an antibiotic prophylaxis, you can do an active surveillance. That is active surveillance whenever there is going to be a fever or minimum symptoms of your urinary tract infection, you do an urine routine and an urine culture and manage them appropriately without starting them on prophylaxis. But it is going to be difficult to follow practically in all children. All children with urinary tract infection are to be followed up. Periodic growth monitoring important because they can go in for growth faltering. Blood pressure evaluation once in 6 months to 12 months, and assess renal function whenever you have a child with a severe complicated urinary tract infection, and urine analysis during each febrile episode in the presence of risk factors. A big thank you to one and all. The thing is open for discussion.
Dr. Sunil, to see the chat box and take up the questions, then expert comments. Sunil, unmute yourself.
Yes, sir. I'll just read, sir. Okay. Dr. Srinath sir has asked, does we need to recommend circumcision to all UTI children?
Circumcision is recommended for all urinary tract infection children, sir. Yes, if it is present, urinary tract infection present, circumcision is to be recommended.
Okay, sir.
Yes.
One more question, sir, has asked. How to check BBD? I think you answered that, sir. How to check BBD? Bowel bladder dysfunction.
Yeah, that's what we have. All the clinical symptoms of your urgency, frequency, new onset enuresis, and the position for holding back the urine, along with your ultrasound features where there is going to be a transrectal diameter, along with your post-void urine volumes, you can suspect an bladder bowel dysfunction and treat it accordingly.
Thank you, sir. Dr. Sumita Nayak madam has asked, sometimes the child is symptomatic, but the culture is negative. How to confirm the diagnosis and manage these kids, sir?
If the urine routine or urine dipstick and your culture is negative, then it is possibly because of the bladder compression or a neurogenic bladder or bladder bowel dysfunction. There could be urinary symptoms. So it doesn't need an antibiotic. If in suspicion, we can have and repeat urine analysis and then repeat culture. And if your ultrasound bowel bladder wall thickness is going to be normal, no urinary tract abnormality, we don't have to treat even if there is going to be minimal symptoms. Possibly it should be because of the compression of the bladder due to bladder bowel dysfunction.
Okay, sir. Dr. Srinath wants to know, we get parents getting child saying child is going often to urination at school, but the urine tests are normal. How to manage these children?
Possibly an irritable bladder. So where your anticholinergics can help relax the detrusor muscle. So sometimes an hyperactive or an irritable bladder can be present. It could also be a sign of a bladder bowel dysfunction, but bladder bowel dysfunction has to be ruled out at the first instance. Once we rule out bladder bowel dysfunction, then we can think about an hyperactive bladder and try with an anticholinergics to relax the detrusor muscle.
Yes, sir. Dr. Pooja would like to know what is the definition of recurrent UTIs?
2 episodes of urinary tract infection throughout the childhood. There is no cutoff timeline, sir. So
Yes.
it is throughout your childhood. If there is 2 urinary tract infection, then it is diagnosed as a recurrent urinary tract infection.
Sir, Annamalai Vijayaraghavan sir want to know indications for antibiotic prophylaxis after first episode of UTI, sir.
Only if there is going to be an primary vesico-ureteric reflex or bladder bowel dysfunction, you go in for an antibiotic prophylaxis. If your ultrasound is going to be normal, there is no bladder bowel dysfunction. As I said, around 40 to 45% of children toilet trained will have bladder bowel dysfunction with whenever you diagnose an urinary tract infection. So rule out bladder bowel dysfunction, rule out vesico-ureteric reflex. If both are absent, no need of antibiotic prophylaxis. If both are present, yes, we may have to go in for antibiotic prophylaxis.
Yes, sir. Dr. Subodh Gupta sir has asked multiple questions, sir. One is, do diaper use increases chance of UTI?
Very much in a female child, sir, because we all know, because I didn't go into the pathogenesis and the other things. It is an ascending infection and the organism is mainly your enteric, that is from the anal area. So they ascend through the urethral tract. If the child is going to void only urine in the nappy, that is not going to be a problem. But we cannot say when it is going to pass a stool and how long it is going to be there in the nappy. So yes, definitely it carries an risk, but all our parents will say we are always checking, we are checking, and we will change it as soon as the child passes, but it is not practically.
Well, second question, sir. Many such patients in whom UTI is suspected have already started antibiotic. How to proceed in such cases?
Already started on antibiotic.
How to proceed in such cases, sir?
Okay. So they say an enhanced urinary analysis, like going in for a gram stain or a counter method for looking in for the leukocyte esterase, helps if the child is already on an antibiotic and you still suspect an urinary tract infection. But it is very difficult to have an clear-cut guideline. Suppose if your symptomatology is going to be very much towards an urinary tract infection and you have any risk factor like your VUR, BBD or a previous history of an urinary tract infection, better to complete the course of antibiotic and then wait for it. So it is again your pretest probability which guides us to complete the antibiotic course.
Yes, sir. Third question is, some labs report pus cells whereas others report leukocytes. Any difference, sir?
Nothing, sir. Leukocyturia or pyuria, both are going to be the same. It is the denatured leukocyte which is going to be called as an pus cells. So depending upon what they look at in the microscope, they are giving. But nowadays, leukocyte esterase is the thing. The dipstick is the one which majority of the labs diagnose with.
Yes, sir. Next question is, 10 to 15% of patients develop renal scarring. How many of these further land up with hypertension?
There are no good long-term studies, but whenever there is going to be a kidney scarring, because the kidney grows even up to the age of 7 years or 8 years, they are bound to develop in long-term complications of your growth faltering and hypertension. But there are no good studies to the so long cohorts to identify the what percentage goes in for hypertension and complications.
Thank you, sir. Thank you.
Dr. Archana Kashyap would like to know how important is toilet hygiene training to avoid recurrent UTIs?
The majority of the time, what the kids do is they go for the toilet. Once they pass the first stool, they think that they have finished passing the stool. They don't wait and they don't have patience to sit for 5 minutes or 10 minutes in the toilet. So toilet training is very, very important, and that precipitates your constipation, and that constipation precipitates your bowel bladder dysfunction. And nowadays, with this Western toilet culture, they don't land their legs on the floor, or they don't have the stool. So the proper positioning and at least making them go and sit at a regular time in the morning, whether they have the gut feeling or not, they have to go and sit there for 10 to 15 minutes. So toilet training goes a long way in helping prevent your constipation or your bladder bowel dysfunction, thereby your urinary tract.
Yes, Dr. Arti Vijayan want to know, does ultrasound finding showing cystitis without any symptoms need treatments?
It could be because of any chemical cystitis, or could be any drugs causing. So not without any symptomatology, it is not going to be needed, sir. If at all in doubt, we can do an urine culture and then say it is sterile, but we don't have to treat it upfront. So don't start on an empirical antibiotic. If you are in doubt, do a culture.
Okay, so Dr. Archana Kashyap want to know, should we remove jet water in commode seeds, sir?
Sir?
Jet water, that spray they use now, sir.
Yes, sir.
For washing post avoiding after passing stool.
Okay.
Should it be removed?
Okay. They say actually the back to front washing culture is what pushes your organisms into the urinary tract, especially in female children. But there are no good observational studies or studies to say what percentage of it helps or causes the trouble.
Yes.
So really no idea about it.
Okay.
Exactly.
Dr. Muhammad Namdar Khan wants to get the PPT, sir. PPT. Dr. Srinivasan sir is very happy with the attendance. Dr. Shashidhar.
Yeah. Even I thought whether I can ask.
Sir, Durai sir, close your screen, sir. So better interaction.
Yes, sir. Yes, sir.
There are some more questions, sir. I'll just complete, sir.
Yes, sir.
Yes, sir. Dr. Shashidhar SB, G6PD deficiency should be ruled out before using nitrofurantoin. Question mark, sir, has put. Should we be doing it?
Generally less than 3 months, we don't use it, sir. After 3 months, we don't go in for a routine testing for G6PD. We start with it, yes, but it is available. Very cheaper test can be done.
Okay. Dr. Varalakshmi M, in case of VUR grade 3 or more with current culture positive UTI and we start antibiotic based on AST, in these cases, how do we decide the antibiotic prophylaxis, sir?
So any child with a grade 3 to 5 needs an antibiotic prophylaxis. As already put up in the slide, you need to continue the antibiotic prophylaxis at least till 2 years of age, and complete toilet training of the baby, and rule out bladder bowel dysfunction, and see there is no urinary tract infection when on prophylaxis for at least 1 year. Then you can stop the prophylaxis. Till that time, once you diagnose with a grade 3 to 5 VUR, you start the child on an antibiotic prophylaxis, and nitrofurantoin is the better drug.
Okay. Dr. Sumita Nayak madam is appreciating, sir. Wonderful presentation, Dr. Durai.
Thank you.
Yes, sir. Dr. Srinath S, frank hematuria in children without pus cells, do we consider as UTI? Ultrasound tells it as cystitis. Culture sensitivity will be negative. After starting IV antibiotics, symptoms will resolve. How to manage such cases?
We all know adenoviral cystitis or an hemorrhagic cystitis is more common during the adenoviral or an viral infections. And if your culture is going to be sterile, yes, possibly it is an viral cystitis and we don't need an antibiotic. Maybe it is a spontaneous resolution simultaneously with the starting of our antibiotic. So not all hematuria is going to be an urinary tract infection.
Sir, Dr. Kalpana Datta madam want to know role of alkalization of urine.
It helps in preventing the urinary irritation, but simple hydration itself is going to be good enough, sir. So the old schools of using your citralca liquid or your other things and alkalizing is not recommended by any bodies nowadays. So increase your fluid intake, that is going to be good enough. But yes, some symptomatic relief if you want to give for an urinary irritation can go ahead, but no clear-cut recommendations.
Okay. Dr. Srinath, yes, sir, is seeing lot of hematuria children after starting mefenamic acid at peripheries. Can we relate it to NSAID-induced pyelonephritis? How you
Yes.
see in such cases?
Drug-induced interstitial nephritis or nephritis causing your hematuria is a separate ball game. Possibly we need to keep them under follow-up, stop the drug, offending drug, check them on for other complications, and then follow it up. Better to be with a nephrologist whenever there is going to be a drug-sensitive interstitial nephritis.
Dr. Shashidhar sir wants to know why this different approach in non-E. coli UTI in investigating the child.
Whenever there is going to be a resistant organism, an unusual organism in a common scenario or a common organism in an unusual scenario, you suspect something abnormal. So whenever you are having a non-E. coli organism as the cause, then you suspect something abnormal because it is a resistant organism. Or this is not a common one. 90% of it is going to be your E. coli and your enteric gram-negative organism. So if you are not going to have that, there is something wrong. So it is given some significance and you need to be behind it to check for if there is an underlying malformation.
Dr. Yogesh sir has appreciated, sir. Excellent presentation.
Sir.
And I think alkalinization, sir, has already answered. Dr. Sumita Nayak, madam, has raised her hand, sir.
Madam.
Come.
Yeah. Thank you, sir. That was an excellent presentation. Just as there was a question regarding the mefenamic acid, sir. So just wanted to share. Recently, I have heard one of the presentations made by Dr. Pankaj Deshpande of Navi Mumbai. That is, he's a nephrologist, basically a ped nephrologist. And they have done a small study wherein they have looked at the outcomes of children who had received, actually, it was children with renal failure. When on investigation, they had renal scarring, etc. When they went back, they have found that those were the children who had received courses of ibuprofen, mefenamic acid, etc. So I think we have to keep in mind the damage, the long-term damage of the NSAIDs when we are, prescribing them as anti-fever medications, etc. So just wanted to bring that point up, sir.
Thank you, madam.
Thank you.
Thanks for that.
Dr. Subodh sir want to speak, sir. Unmute, sir. Unmute, sir.
Sir, in few cases,
Nimacillate and naproxone were very much used those days. I used to be as a rational use. The thing I advocate, I have been against it, and I was telling. And you are advertising in Indian pediatrics. That's not correct. Finally, it went away.
sir, my question is that in few cases, what we have seen that a suspect UTI case, antibiotic was not started, urine culture was sent, and urine culture report received say after 3 days or so, sometime in between there is a Sunday. By the time the child is okay without any antibiotic, but culture report says this organism with full picture of this resistant to this and sensitive to this, then how to proceed in such cases?
Possibility of contamination, sir. Even the best possible collecting method of your ultrasound guided suprapubic aspiration has 1% of your contamination. So the clean catch methodology itself has around 5% chances of contamination. Suppose if the child is clinically better, no urinary symptom, no fever, not toxic, and your urine analysis also showed no leukocyturia or pyuria, then possibly ignore it as a contamination. If you are in doubt, you can go in for a repeat culture. If not, wait for the symptoms to appear.
There is one more question, sir. Role
Sir,
of
thank you.
circumcision in absence of phimosis.
Generally, the literature is circumcision helps in preventing recurrent urinary tract infections. There is no doubt about it. It is very much proven. So if you have an urinary tract infection, even in adults, diabetics having an urinary tract infection or an melanocystitis, circumcision is advised. So circumcision definitely helps in preventing an recurrence of urinary tract infection. So if the parents are okay with it, it can be done.
Considered. That was very nice, sir. One more, Dr. Nagesh sir has asked, sir, if urine analysis is normal and culture is positive, suggestive of UTI, what would be the best approach?
Sir, if urine routine is normal,
culture is positive or suggestive of UTI, what would be the best approach?
Sir, the urine test can be normal because I said 10 to 15% of our organisms won't have an leukocyturia, and especially in infants where they are voiding more frequently, we can miss on an leukocyturia and we can miss on an bacteriuria because the oil immersion field has to be seen under the microscope. Now it is labor intense. Most of them don't have the patience to look at it. So majority of the time you can have your leukocyte esterase negative or your nitrate negative because 4 hours of incubating time may not be there. But your culture is going to be gold standard. If you have a clinical suspicion and your culture is positive, yes, treat it as an urinary tract infection.
One more, sir, similar. Is it necessary to repeat urine culture after a course of antibiotic?
Not at all needed, sir. If the clinical symptomatology is okay, the child is fever difference within 48 to 72 hours, and you complete the course and then leave it. Don't have to prove that the urine has become sterile.
Okay, sir. One more question is practical question, sir. If
Sir.
patient is clinically responding to antibiotic, but on culture organism is resistant, then what is the next step?
Majority of the time, there is a discrepancy between your in vivo and in vitro sensitivity, sir. If the child is going to be clinically responding, the take is to continue with the same antibiotic. Possibility that the in vitro and in vivo sensitivity is different.
Yes,
because clinical response has to be always given the credit, and the same antibiotic can be completed for 7 to 10 days.
Yes, sir. Dr. Srinivasan sir has written, good to see all are happy and satisfied with all the answers. That was very practical questions and practical answers, I think, sir. Very nice of you. Sir, any further comments?
Not only me, so many people have praised.
Yes, sir. Yes, sir.
Thank you, sir. Thank you, sir.
People in infection disease also praised.
All people are happy, I think, sir, today.
Kalpana Datta madam is there? Annamalai sir, your comment, sir.
Sir has joined from US again, like Srinivasan sir.
Very nice talk and very useful for all the pediatricians. And I must appreciate Professor Durai Arasan. Professor Durai Arasan has, the very useful time spent. We have listened to the nice talk from him, and all the questions were very nice, and the answers were, as you said, was satisfying. Thank you, sir.
Question and answer.
Dr. Nandis, I'm
as
here.
good. Yeah, Madam Ji, please.
Yeah, it's a wonderful session and thorough. Lucy, he didn't leave any points, and a continuous flow was there, and many practical tips were there. So, and there is some change. Actually, we knew the intravenous antibiotics is given below 3 months. He has shown 2 months. I think is there a recent change for that? I don't know. Is it that?
The guideline says less than 2 months. Even if the child is okay, don't go.
In the Nielsen, it is written 3 months actually.
Yes, madam. Even if the child is stable, go in for parental antibiotic.
Wonderful session and many learning points.
Thank you, madam.
Question and answers were as good as your presentation, sir.
Thank you. Thank you, Nandis, for giving me the opportunity.
No one
Yogesh
wants to
Parekh
leave.
is
Yes, thank you. Thank you very much. And I've already written in the chat box.
Sir,
It's
thank
an
you, sir.
excellent presentation, sir.
Thank you, sir. Thank you so
Yeah.
much.
any other seniors? Are there any students who wants to clarify? Sunilji, please check any other senior.
Yes, sir. One
Dr.
more
Sharath.
question, sir. One more question they have typed, sir. If patient is asymptomatic and active, but urine culture is positive, what is to be done?
Sir, asymptomatic children don't go in for an urine culture. That is what is, because it could be an asymptomatic bacteriuria, we don't know. So asymptomatic bacteriuria doesn't require an antibiotic therapy. So if there is no symptomatology, and routine urine culture is not warranted.
Okay, sir.
So could be possible asymptomatic bacteriuria.
Sure, sir. Sure, sir.
Yeah.
If there are no any comments further, I would like to request Dr. Raghunath sir to give his closing points.
Thank you, sir. Thank you all the seniors. Thanks for
We
your
are deeply indebted to your commitment, sir, and
sir,
teaching.
thank you.
Very nice. Thank you very much.
So much, sir.
Raghu.
Sir, thank you very much for updating.
Thank you, sir.
Yes.
Thank you.
Many
Good
points
night.
for the presentation. And thank you,
you,
sir.
sir.
And we look forward to more interaction with us in the later days. Thank you very much. Over to you, Dr. Sunil.
Yes, sir. So last thing is the vote of thanks. On behalf of IAP Bangalore, I would like to thank first and foremost our President, Dr. Raghunath sir, for continuing with this wonderful program, and Dr. Nandi sir for every month coming up with the wonderful speakers and wonderful topics, and bringing all the VIPs and all others. We thank Dr. Sumita Nayak Madam, who started this program last year as Bangalore Connect program, and we have progressed to Great Bangalore Great Bangalore Connect program. Thank you, Madam. We thank on behalf of IAP our other EB members who were there, OB members, Dr. Sharath Chand sir, Dr. Ish Hoskote sir, Dr. Geeta Patil Madam, Dr. Sahana Devdas Madam, Dr. Srinivasan sir, Subodh Gupta sir, Kalpana Datta sir, Madam, Annamalai sir, and all other OBs and EBs who were present today. Special thanks, because of whom this program was successful. We had more than 100 people and people waiting outside. We could not accommodate them, maybe because of the topic and the practicality. We thank Dr. Durai Arasan sir for sparing his time and enlightening all of us. Thank you. Thank you very much, sir. Good night.
Thank you, sir.
Dr.
Thank you to
Sunil.
one and all. Thank you,
Yeah.
sir.
Good night.
Special thanks to Dr. Jose sir and Dr. Yogesh Parekh sir, who were present throughout the program, sir. Thank you.
Thank you. Thank you. Thank you,
Thank you,
Bangalore team.
Thank you, sir. Thank you. Good night, sir.
Thank you.
Good
Good
night.
night, also.
And thank you, Nandi, by putting all the posts in all the groups. So if you are posting in all the groups, then people will connect to the Bangalore Connect. Thank you.
Thank you, sir.
Thank you. Thank you.
Bye.
Thank you.
Good night, sir.
Good night.